My name is Susan Hwang. I'm a neonatologist in the NICU, the Neonatal Intensive Care Unit at Children's Hospital Colorado and at University Hospital. I'm also an assistant professor of pediatrics at the University of Colorado School of Medicine and the physician lead for our state's perinatal quality improvement collaborative focused on care of the opioid-exposed newborn. The transition of care from hospital to home is critical for infants with prenatal opioid exposure. We know that these infants are at high risk for attachment disorders, neurodevelopmental and behavioral issues, safety concerns due to potential drug-seeking behaviors of their parents. Thus, discharge of any infants exposed to substances, either prescribed or illicit, should include careful planning and involvement of a multidisciplinary team. Concomitant to this, there has been recent legislation called the Child Abuse Prevention and Treatment Act, or CAPTA, which is a key federal legislation that addresses child abuse and neglect. There was a recent amendment in 2016 with the Comprehensive Addiction and Recovery Act, which added criteria to state plans to ensure the safety and well-being of infants following the release from the care of healthcare providers. This law addresses the health and substance use disorder treatment needs of the infant and affected family or caregiver, and seeks to develop the plans of safe care for infants affected by all substance use, not only illegal substance abuse, as was the requirement prior to this change. A multidisciplinary group in Colorado embarked on the development of discharge guidelines to meet these CAPTA goals. Adapted from the 2008 AAP guidelines from the Committee on Fetus and Newborn regarding the hospital discharge of the high-risk neonate, the plans of safe care for opioid-exposed newborns includes assessment of the physiologic readiness of the infant, discharge planning, arrangements for follow-up, and parent-caregiver education. Regarding physiologic readiness assessment of the infant, we recommend close monitoring for signs of withdrawal using the Eat, Sleep, Console tool. We recommend observation in the hospital for at least 72 hours prior to discharge. And those infants who require pharmacologic treatment for neonatal abstinence syndrome should be stable off all medications for at least 24 hours prior to discharge. We do not recommend infants being discharged on medical treatment for NAS. With respect to discharge planning, we think it's essential for there to be development of a comprehensive home care plan that should be completed prior to discharge by a multidisciplinary group. Components of a home care plan should include the following: identification of in-home caregivers, formulation of a plan for nutritional and medical care, development of a list of required supplies, if applicable, in the home, identification of primary care physician, identification of community resources and treatment programs for parents, assessment of the home environment, development of emergency care and transport plan, and assessment of financial resources. With respect to arrangements for follow-up, there should be verbal communication with the primary care physician prior to discharge. We recommend neurodevelopmental follow-up or early intervention referral prior to hospital discharge. Follow-up for the parents should also be identified prior to discharge. Follow-up for the mother should be arranged with her obstetrician or gynecologist. The families should also receive follow-up with a social worker or a caseworker shortly after discharge. Finally, follow-up with the treatment program and/or counselor for the family member with a substance use disorder is also suggested. With respect to parent and caregiver education, parents and caregivers must be present during birth hospitalization and display competency in cares of the infant prior to discharge. When possible, at least 2 caregivers should be identified. These parents and caregivers must exhibit readiness to assume full responsibility for the infant's care after discharge. Development of an individualized teaching plan is essential. You should also consider creating a checklist or outline of tasks to be completed. We recognize that as the length of stay for opioid-exposed newborns is getting shorter, the opportunities to address these components of a safe discharge may become more limited. Thus, we all have to be very vigilant about optimizing the transition home for both the mother and the infant, ensuring that the two are considered inseparably linked as a dyad. I'd like to acknowledge our partners in this statewide effort, Illuminate Colorado and the Colorado Perinatal Care Quality Collaborative. For more information, please visit our website.